if a child comes to you with a complaint of urinary tract infection in the form of urinary urgency, hypogastric pain, or increased frequency of urine, or going urgently to the washroom and saying that I'm feeling like peeing. So in that case, when you go for urinary urine culture, you do see a single organism growing more than 10 per 5 organisms per ml. If it is less than 10 per 5, we would say this could be a contamination, but this is not the pure organism causing urinary tract infection. So it is more common and important clinical problem in childhood, and urinary tract infections is basically the acute pyelonephritis. And this is a disease which seems like a very innocent disease, but if it persists for a longer time period, it can lead to renal scarring, hypertension, and ultimately to the end stage renal disease. So we will talk about the incidence. It varies markedly with the age and the gender of the baby. It is twice as common in boys before the 1 year of age, and in childhood 10 times more common in girls. So if you see a boy less than 1 year of age, and especially when the circumcision is not done, there's a chances 2 times more chance to for the boys to get the urinary tract infection. Although it gets higher, it gets 10 times than the boys and girls when they are less than 5 years of age. So around 2.5% of school age girls have UTI. So incidence, you would say that it is approximately 2.5% in girls of school age, and 60 to 80% chances of recurrence. So it is very important, if you see a patient first time with urinary tract infection, you need to reevaluate them, because there's a chance of 60 to 80% that they can have a urinary tract infection again. So when we talk about the etiology, so we know that the E. coli is the most common bacterial cause of urinary tract infection, and it accounts approximately 80% of the urinary tract in children. So if a question comes, if somebody asks you what is the most common organism which can cause urinary tract infection, so it is culture proven, it is study based, it is literature based that 80% of the UTIs in children are because of Escherichia coli or E. coli. While there are other organisms which can cause urinary tract infection, in which Klebsiella, Proteus, Enterobacter, gram-positive bacterial pathogens like Staph, Streptococcus, and Enterococcus. These are the organisms which commonly occur in urinary tract infection in pediatric age group, but the most common, which accounts for 80% of the urinary tract infections, is E. coli. When we talk about the risk factors, the risk factor for the fungal UTIs are, we know that whenever we do prescribe immunosuppressive medications or long-term antibiotics to a person, so there is a chances of having fungal UTIs, because their body is immunocompromised, and especially when they have indwelling urinary catheter, which is usually of silicone or plastic material, there's a chances of fungal growth in the urinary tract infection. While viruses are very less common cause of urinary tract infection in children. So in etiology, the E. coli is the most common. There is others are Klebsiella, Proteus, Enterobacter, Enterococcus, gram-positive bacterial pathogens. And the risk factors or fungal UTIs are immunosuppression, long-term use of antibiotics, and indwelling urinary catheters. Now it's important, when we talk about urinary tract infection, we all know that the kidney is, the kidney system is the kidney, the ureter, bladder, and then urethra. So there is upper urinary tract infection and lower urinary tract infection. It can be difficult on clinical grounds to differentiate between the cystitis, which is basically the lower urinary tract. So whenever there is involvement of infection in urethra and urinary bladder, we will call it lower urinary tract infection. And whenever there will be inflammation of the kidneys as well along with the bladder or cystitis, you can say, then we will call it upper urinary tract infection. Upper urinary tract infection is a more severe form of urinary tract infection, and it increases the risk of renal scarring, because in this case, in upper respiratory tract urinary tract infection, upper urinary tract infection, the kidneys would be involved, so there will be more risk of renal scarring. In this case, you usually have high-grade fever, which is more than 39 degrees centigrade. It can be more than 48 hours of duration. Patient would be sick looking. They can be costovertebral angle tenderness, which is at the back between the spinal cord and the rib cage, there's an angle called costovertebral angle, and when you press over there, this could be tender because of the underlying kidneys which are inflamed, and patient can show the tenderness over there. Similarly, if a child who's on known immunodeficiency, like somebody, some baby who's suffering from congenital immunodeficiency syndrome or HIV, which is after 10 years is common in kids. And similarly, any urological abnormality, whenever there would be stasis of urine in the system, there's a chance of urinary tract infection, and that can cause upper urinary tract infection. So when we look at the sign and symptoms and we try to differentiate, so you can see there's the first, wait, let me take the arrow. So when we look at the sign and symptoms, and when we look at the pyelonephritis and the cystitis, so pyelonephritis is upper urinary tract infection, and cystitis is just inflammation of the bladder. We call it lower urinary tract infection. So fever will be more common in case of pyelonephritis because it is going to take more of the systemic type of illness, while in cystitis it will be very local inflammation, so there will be less chances of, it will be unusual to have fever, which is more than 39 degrees centigrade. Constitutional symptoms means lethargy, nausea, lack of appetite. It all is more common in case of systemic illness, which is pyelonephritis, which is upper urinary tract infection, and it is less common in cystitis. When we look at the WBC counts in on blood sample, you would see there will be more WBC count because I just told that it would be more of a systemic illness. So a WBC body reaction will be more in pyelonephritis, but it would be very unusual, or the WBCs would be normal in case of cystitis. When we look at the elevated ESR, it is usually always possible in pyelonephritis, but it would be unusual in cystitis because it is a local illness and it is a systemic illness. And elevated ESR, which is erythrocyte sedimentation rate, and it is basically acute phase reactant, and it shows that the body is having some reaction against something. So whenever there will be raised WBC, there will be raised ESR because this is erythrocyte sedimentation. The more cells, more ESR. Dysuria is more common in case of cystitis because whenever patient passes the urine, it gives a complaint of undiscomfortable or pain feeling in bladder region, while it would not be possible. It would be possible that if there's cystitis plus pyelonephritis, it is variable. So whenever there will be involvement of the bladder, there would be chances that in case of pyelonephritis, there would be dysuria frequency or urgency. In case of DMSA, DMSA is the scan which showed the uptake of the radioactive dye in the kidney. So whenever there will be pyelonephritis, we just talk about it in a few slides back that whenever there will be pyelonephritis or upper urinary tract infection, there will be more chances of scarring. So whenever there would be a scarred kidney, there would be less tissue which would be taking less dye in it. So in cystitis, kidneys would be normal, so the DMSA scan would be normal, while it would be, there would be areas of decrease of uptake in case of DMSA scan. When we talk about flank pain and costovertebral angle tenderness, it would be common in pyelonephritis, but it would be absent in case of cystitis. So, if you talk about the pathogenesis like why is it happening? There are multiple reasons which causes pyelonephritis or upper urinary tract infection. It could be because of fecal flora contamination. Means it is very important whenever you see a patient, and if it's a girl, you need to tell the parents, and even you need to teach the child who's more than 5 years age to the washing techniques. So washing techniques should be like the person should not be while washing their after defecation, they should not be washing their bottom from back to forward movement, so that otherwise there could be contamination of fecal flora, or even prolonged use of diaper with fecal material in it can cause fecal flora contamination of the urethra, especially in girls. When we talk about vesico-ureteric reflux is a structural issue in the kidney when there is reflux of urine from bladder to urethra. If we look into it, let me show you something. So when we look at kidneys, we know that Allah Ta'ala has made a process that urine would be formed in the kidneys, right? This area here, urine will be formed, and then ultimately it will go down in the ureter. But and from ureter it goes into the bladder, and then from bladder it goes out of the body. But if there is vascular-ureteric reflux, there's a chance whenever there'll be increased pressure on the bladder from this side, this side, this side, because whenever a baby would try to urinate, there would be increased pressure in the bladder, and this increased pressure causes the urine to gush out. But whenever there is vascular-ureteric reflux issues, whenever there will be vascular-ureteric reflux issues, so whenever the pressure was raised here, the urine would go on the backward direction as well. Although normally there is a valve which causes just one direction flow from kidney to the ureter and ureter to bladder. But in case of vascular-ureteric reflux, this urine would go back into the ureters, and the level of vascular-ureteric reflux is going to cause level of damage. So it is being graded into 5 grades: grade 1, 2, 3, 4, and 5. If you look at this grade 1, it shows that there will be no dilated ureter. You can see, I hope this is evident to all of you. Let me make the screen big. Sorry. Okay, so I'm sorry if it wasn't very clear initially. So when we look at this, and when we again start drawing in here, so you can see that urine was coming here, and then it was coming down, and then it was going into the bladder, and then it was going out of the body, right? So here when we talk about the vascular-ureteric reflux in grade 1, this you can see the yellow color in the bladder, and this yellow color is trying to show the urine in the bladder. And this when while passing urine, when this urine goes into this part, this is the lowest one, I would say fifth of the ureter, but the ureter shape is normal. This is non-diluted. No, actually this is dilated. Non-dilated ureter is the grade 1 with some reflux in it. When we look at the grade 2, there is reflux going up till this pelvic ureteric junction. But if you look at the shape of the ureter, there is no dilatation in it. So this is our normal ureter. But when we talk about the grade 3, which shows that dilated ureter and or blunting of chelical forces, means the urine is going from bladder to ureter, ureter to pelvic ureteric junction, and then ultimately is going into the chelicus as well. So there will be slight blunting of the chelicus. So, but there is no shape is being deformed of the kidney. But in grade 4, this would be further dilatation of the pyramids, and ultimately, and there will be some dilatation in grade 4. There will be dilatation of the ureter. But in grade 5, there will be a gross deformity of both the kidney and the ureter. So this is grade 5. So you need to revise it in grade 1, no dilated ureters. In grade 2, upper collectic system without dilatation has been involved. In grade 3, there is dilated ureter and blunting of the chelical forces. Then grade 4, kidney and grossly dilated ureter. And grade 5, there will be massive reflux into the kidneys, which is causing tortuous ureter, which is basically causing this much of damage to the kidney. So this could be a reason when we say that kidney can be damaged because of the vascular-ureteric reflux. So what are the main reasons for, what are the predisposing factors or the risk factors for urinary tract infection? So poor hygiene, whenever there would be unhygienic condition, not dealing rightly with the, with the, I would say the genitalia, then there would be chances of increased urinary tract infection. Similarly, constipation is another cause which can cause increased chance of increased incidence of urinary tract infection. Similarly, pain bumps, presence of some foreign body which is in the form of stones, which actually are being formed in the kidneys, and they they come down into the ureter and the bladder. Then posterior urethral valve is another anatomical structural issue which causes stagnant urine. which causes hydrostasis or the urinary stasis, which can cause urinary tract infection. Similarly, hydronephrosis means abnormally dilated pyramids, and the cheilitis of the kidneys can cause stasis of urine, which can again cause urinary tract infection. Similarly, abnormality of the kinetic system and female gender, after 1 year of age till the school age, female gender is more prone to develop urinary tract infection. So predisposing factors which are related to the host leads to the patient. It's the age. We know that the UTI is more higher in boys when they are younger than 1 year of age, and it is more in girls when they are younger than 4 years of age. Whenever there is lack of circumcision, uncircumcised males are more prone to develop urinary tract infection, and there is 4 to 8 fold higher incidence of urinary tract infection in uncircumcised males. Female infants are supposed to have 2 to 4 fold more chance of urinary tract infection. There is genetic factors as well. It has been seen that it runs in the families that first degree relatives of children with UTI are more likely to have UTI than other individuals, such as without any history. And urinary obstruction, I told you, whenever there will be stasis of the urine, there will be chances of growing more bacteria. So children with obstructive urological abnormalities are at the risk of developing urinary tract infections. When you look at the investigation, if a child comes to you and you suspect that this patient is having urinary tract infection, you need to go for complete blood count, urinary detailed report, urine culture and sensitivity. You can go for imaging like ultrasound. MCUG is the thing which basically is going to help you to diagnose. This is going to diagnose. Sorry, let me. It is going to diagnose this MCUG. Sorry. This MCUG, just look at this and you can see that this MCUG is going to, what's going on? Okay. This MCUG is going to diagnose ureteric reflux, and DMSA is the thing which is going to help us in diagnosis of scarring of the kidneys. And again, we know whenever there is a case which is prolonged urinary tract infection, a child comes to you with repeated urinary tract infection, you need to look at renal function test, because whenever there will be ureteric reflux, which you are going to diagnose by doing MCUG, you know that whenever the kidney structure is being damaged, the renal functions would also be affected. Similarly, whenever there is repeated UTIs, there would be a chance that there will be scarring of the kidneys, which you are going to diagnose by the help of DMSA scan. And definitely, whenever there is scarring, there is a chance of renal function disorders. So we need to investigate the child with repeated UTIs. So what is the goal of treatment of UTI? The goal should be that we should eliminate the infection and prevent the urosepsis. We need to relieve the acute symptoms like fever, dysuria, and frequency. We need to prevent the recurrence and long-term complications, which we know that it could be renal scarring. Renal scarring, it would cause shrinking of the kidney, which would ultimately lead to hypertension. Renal scarring can also cause renal function issues and ultimately can affect the growth of the baby. So, usual indications for hospitalization or parenteral means IV antibiotics to be given in a child should be, if a child is less than 2 years old, we need to admit that patient, we need to give IV antibiotics. If there is clinical urosepsis and if the patient who seems like toxic in appearance, there is hypertension, poor capillary refill, we need to give them IV antibiotics and we need to hospitalize them. We know a child who is immunocompromised in the form of that he's on some immunosuppressive medications, a baby who's malnourished, so we need to admit that. Similarly, vomiting or inability to tolerate oral medication. We know that if we are going to prescribe medication orally, if a child is vomiting, he is not going to tolerate the medicine as well. So we need to admit them and give IV antibiotics. There can be lack of adequate outpatient follow-up if a child comes to you from far away. If you're in Karachi and he comes from Hub or Quetta or Balochistan, I think that would be the candidate to ask for the admission and give IV antibiotics. Similarly, our child who was being treated initially as an outpatient was on oral medications. Now the response has not been coming up after 48 hours of medication. then it shows that there is failure of response to outpatient therapy, so we need to admit them and give parenteral antibiotic. So what the normal treatment we advise? It's usually amoxicillin, co-amoxiclave, nalidixic acid, nitrofurantoin, cefixime, ciprofloxacin. These are the dosages and the durations written over here. You can find this in the book as well. So I would say you better, when you read it, this UTI from the book, you better go into the detail of this treatment and what are these medicines. I think it's not the time here to focus on this. So what is the clinical response to therapy? If you have diagnosed a case, a child comes to you with urinary issues, then you diagnose him on the basis of CBC, urine culture, and ultrasound that this patient is suffering from urinary tract infection. Then you have given the medications. Now what is the response you want to look for? So the clinical condition of the most patients improve in 24 to 48 hours. So if a child comes to you with fever, burning micturition, urgency, hypogastric pain, so if you would start the medication, you expect in 24 to 48 hours, the symptoms would get improved. But in children with clinical condition has not been improved, either has gotten worse or the fever is persisting despite giving antibiotics for 48 hours, and you need to look at to revise your antibiotics. You may need to broaden up the antibiotic therapy coverage. And in that case, you may need to look into the culture and sensitivity of the urine culture so that you can treat the child with the appropriate antibiotic. So what are the preventive measures? We know bad hygiene was the risk factor, so good hygiene can prevent. We know the constipation is the risk factor, so avoid constipation. We know urological issues are the ones which can cause repeated UTI. So you need to rule out if a child, either if he's having vesicular-ureteric reflux or any other urinary tract abnormality. So we need to treat that cause, and we can start with prophylactic antibiotics. And prophylactic antibiotics are usually in the smaller dose. They're usually once a day treatment so that it avoids the growth of the organism inside the urinary bladder and the urethra. When we look at the complications, we know whenever there would be repeated urinary tract infections and all, we need to, we know that these are the complications which can come later on in this patient. These complications could be, I would say, first would be the renal scarring. We know whenever there will be renal scarring, the renal tissue would be compromised. There would be shrinking of the kidney. Whenever there will be compromised kidney function, whenever there will be shrinking of the kidney, it would cause hypertension. So hypertension, renal scarring, and ultimately when a kidney is not having a good tissue structure, it will ultimately end up as in renal failure. So it can end up as chronic renal failure. When we talk about the follow-up, so you know you have diagnosed a patient with urinary tract infection, you have given the antibiotic, it has started improving. We should ideally advise urine CS 1 week after stopping the antibiotic. So you want to make sure that yes, you have treated the infection completely and there is no recurrence of the infection. And they should be checked for recurrence every 1 to 2 months. So if you have seen a patient with urinary tract infection, you ideally should see them every 2 months for at least 1 year to see that this patient is not having recurrence of urinary tract infection. And if a patient comes to you and is having recurrent urinary infection, you need to actually evaluate what is the reason behind that. So prognosis is that low urinary tract infection, which is more of a local issue, has got an excellent prognosis. But if a child who has pyelonephritis, it's a guarded prognosis in a sense that if a child develops only once pyelonephritis, there's a chance that the excellent prognosis is there. But if a child is having repeated pyelonephritis, your treatment, your management, your patient's response, everything is going to guard the prognosis. So the prognosis is guarded with that. So this is it. Thank you so very much. I would say if anybody has any question, please do ask or write it in the chat so that I can answer the questions.